polycystic ovarian syndrome, which is a terrible name for what the condition actually is, but it is a complex heterogeneous disorder, meaning not everybody's PCOS looks the same, but it's characterized by ovulation disruption, so dysfunctional ovulation, which may result in irregular periods or delayed ovulation, delayed period, an excess of androgens, which are hormones in our body that women and men have. Men have in higher proportions than women, but having more androgens in women or other people with ovaries can result in some symptoms: acne, facial hair, hair loss, etc.
And you said it was a terrible name.
The name polycystic ovarian syndrome implies that people have lots of ovarian cysts. And the name came from a characteristic appearance of the ovary on ultrasound, where there are little small cysts called follicles, which are the little small cysts that house our eggs, line up around the edge of the ovary. So they're not cysts in the way that you would think of, that caused pain or, that may result in needing surgery. So it's not, and not everybody with PCOS actually has this appearance on ultrasound. So for that reason, I think it's not such a descriptive name for what the syndrome really is.
Yeah, so it's probably something that was found once and then the name stuck and just never changed. So you don't need to have cystic ovaries.
So we now use, there are many different criteria out there, but the main one and the one that's really recommended by most international societies is called the Rotterdam criteria, in which you need 2 out of 3 characteristics. And so those are irregular or infrequent ovulation or menses, menstruated androgens, either by blood test or by symptoms. And then thirdly is that appearance on ultrasound. So you can have the first 2 and not the third and still have PCOS. You're welcome.
Okay. All right. Great. Thank you so much. So once you have PCOS,
it can't be cured. PCOS is a chronic disease, and it has multiple different causes. And in any one person, there are probably multiple different factors. So there are about, as we know, 20 different candidate genes, so genes that may be responsible for PCOS, plus there are epigenetic changes, which are changes due to exposures when we're fetuses in our mom's uterus, and then many environmental factors that factor into PCOS, including nutrition and lifestyle, and then other, environmental toxins and such. But just because PCOS can't be cured, it can be managed such that most of your PCOS symptoms can, be minimized or eliminated, but that underlying risk is still there.
And there's no way to remove the cyst from
without removing all of your, your eggs, your follicles, which, certainly we don't want to do that. Well, actually,
that even help?
A treatment of old. They used to do what's called a wedge resection, where they would actually remove part of people's ovaries to minimize the impact of having all those what we call sort of unready follicles or antral follicles, and it was called a wedge resection. But that is not something that's done anymore for obvious reasons. We don't want to be taking away people's eggs and their ovarian tissue.
What are some of the kind of more common treatments for PCOS these days?
PCOS, even though it's not part of the diagnostic criteria, 75 to 95% of people with PCOS have insulin resistance. So some of the treatment centers around treating the insulin resistant. Number 1, first and foremost, everybody who has a diagnosis of PCOS should be counseled about nutrition and other lifestyle factors like sleep, really important, exercise, and stress management. And then looking at what a particular person's, through their lab values and the symptoms they experience is going to guide the treatment. So probably I'll just talk about the first 2 most common treatments. The first one being oral contraceptives. And there's a lot of controversy in the PCOS world and PCOS space about the use of oral contraceptives to treat PCOS. And I think really the problem lies in the education around why it may be a good idea for certain people. And so what oral contraceptives do for people with PCOS are basically three things. One, it helps to give people a predictable menstrual cycle or a predictable period, even though it's not a real period. That helps with people who really struggle with, the annoying surprise periods or the annoying really heavy periods that can come along with PCOS. Number two, because people with PCOS often have an excess of estrogen and an inadequate amount of progesterone, we produce progesterone, putting people on oral contraceptives actually reduces the increased risk that they have of something called endometrial hyperplasia, which is a precancerous condition to endometrial cancer. And that is something that's more common.
Okay.
And then lastly, oral contraceptives that have estrogen in them increase a protein in our blood called sex hormone binding globulin, and that protein actually binds to testosterone, and that helps to treat symptoms like acne and facial hair. So even though it's not a cure for PCOS, it is a great way to manage multiple symptoms. That being said, people need to be educated about why it's being used. They need to understand that when they stop using it, they may have a resumption of their symptoms. It's not going to cure their symptoms. And so there needs to be a really thorough risk-benefit discussion. And not everybody's a candidate for combined hormonal contraception. So some people just can't take estrogen because of other health conditions that they have. So I think a lot of the backlash against oral contraceptives in PCOS comes from really just a lack of that discussion happening. And then, go ahead.
Yeah, I was going to ask you now about lifestyle changes because, I know that's an area of your expertise. What's the role of weight loss, if any, in managing PCOS?
Unfortunately, people with PCOS have this metabolic dysfunction. Many, like the vast majority, have insulin resistance, which can make weight loss more challenging than for somebody who doesn't have insulin resistance. Now, the problem with insulin resistance is it makes it harder to lose weight, but then also having an excess of body fat also can worsen insulin resistance. So it is this sort of vicious cycle. It has been shown that modest weight loss, even if it's just 5% of body weight loss, can improve the insulin resistance and then can improve PCOS symptoms. Although I always caution and I always worry, because I'm somebody who really counsels people about nutrition, that is the weight loss really a proxy for just all the improved behaviors that are getting us to the weight loss? And is that improving the PCOS versus is it actually the reduction in body fat? So, I always try to focus on the behaviors as the goal and the improvements of the symptoms as a goal versus, solely weight loss.
That makes a lot of sense. So what kind of behaviors specifically do you see that? So
for people who, especially for people who have insulin resistance, reducing the amount of refined carbohydrates, obviously, and increasing fiber intake. So increasing whole grains, fruits, vegetables, legumes, beans, lentils, educating about how to combine meals so that people feel full and are getting enough fiber and are getting enough protein and are getting enough healthy fats. Getting enough healthy fats is really important. Right. So trying to shift away from saturated fats to monounsaturated fats and getting enough omega. So, there's a lot of, and then including things that are, nuts, I think are really also a great source of getting those healthy fats and good snacks. And so finding out where people are and just trying to move towards a place that is going to, suit them and work better for them and alleviate some of the insulin resistance.
What kind of nuts specifically? All nuts?
Yeah,
or anything
a good variety. Each of them sort of have different. Almonds are a good source of calcium. Walnuts are even a really great source of ALA. Brazil nuts have selenium. So trying to mix it up.
Awesome. And so getting back to the weight loss question, you said 5%. What is the there's really no benefit beyond 5%.
There might be benefit beyond 5%, even 10%. it really depends on the degree of somebody's adipose. And also, it's important to acknowledge the weight loss should be fat loss. And so that people are not really restricting too much so that they're losing lean body mass, because lean body mass is very difficult then to build back up. And that's important for health, and that's important for insulin resistance, and that's important as we age. And so losing lean body mass is not going to be helpful. So, if somebody really has a lot to lose, then maybe there may be multiple benefits for them losing a larger amount. But studies have shown people need to, that benefit really starts at 5%. And so it doesn't mean that, more isn't going to make additional improvements, but, weight loss is hard. So we try not to make it so difficult that the goals are impossible to reach.
People talk a lot about metformin and PCOS.
So that's the other.
What are your thoughts?
I said I wanted to talk about two different medications. The other one would be metformin or other insulin sensitizing agents. So metformin is the prescription medication that we use for insulin resistance. There's a supplement that has just been demonstrated to be as effective as metformin, and that's called inositol, and that's a very popular supplement that people with PCOS use and find good results. And then there are a few other, I don't want to get into the other supplements, but there are some other agents out there, but those are the two most popular. And helping the insulin resistance helps the ovary to function, and it also helps with weight loss.
Awesome. So this was such a fantastic discussion. Before we say goodbye, any other final kind of recommendations from the dietary's perspective and as a perspective of,
So I would say the thing that really motivates me is what I've seen over the years in my work as a dietitian nutritionist and as an OBGYN is that oftentimes PCOS is treated, multiple different disorders. And so people often go to multiple different specialists to manage their symptoms. So sometimes by the time I'll see somebody, they've seen a dermatologist, they've seen an endocrinologist, they have a psychiatrist, because there's all these different conditions that go along with PCOS that are not managed as a whole. And so people end up being on multiple different medications and don't really know what's going on, and maybe haven't had a thorough discussion about what is PCOS and what is the impact on their life, because it is a chronic disease that's going to affect people at different life stages. So it may affect your period and you find that annoying. But if you don't also appreciate the fact that it may make it difficult to get pregnant. Sometimes people find, that's not on their mind at the time of their diagnosis, and they're blindsided, 10 years down the line when they decide they want to start a family. People also need to appreciate the fact that it increases the risk for diabetes, it increases the risk for gestational diabetes, it increases the risk for heart disease. People with PCOS often are, they're at higher risk for mood disorders. So the discussion really needs to be happening at the time of diagnosis. And I think we as OBGYNs, family physicians, primary care physicians, even pediatricians who are seeing, people in adolescence in their late teen years need to do a better job about laying out what does PCOS mean across the lifespan, so that patients really have a better understanding and can really take charge of their life and be more involved in their health decisions, and really appreciate why they need to make some of these changes.
Yeah, that's so true. The education is really half the battle when it comes to especially chronic diseases. Well, this was really, really helpful. I learned so much. Where can our followers find you, on Instagram, social,
so you can find
or your
me
website?
On Instagram at Dr. Basma Farris. I also have a website, Basma. I'm weeks away from launching a telemedicine practice for people with PCOS. Right now, I'm only licensed in New York and Florida, but if you reside in New York or Florida and you'd like to see me, you'll be able to do that soon. So you can just follow my social. Instagram for that practice is PolyPrep, P-O, and the name comes because really it's all about education. So it's prep school for your PCOS, and then you'll be able to find out when I'm ready to open theoretical doors, because it's going to be All telemedicine.
Awesome.
Thank you.
All right. Well, great to have
Thanks
you.
for having
Thank
me.
you so much for sharing all your information.
Bye.